his nickname was, and we've only met him recently, and it sounds like everyone does the full pronunciation, full Beowulf pronunciation. I don't know
Ah,
what you'd go by. I'd probably go by Wolf because I mean,
no,
why not?
obviously.
Yeah, that's a pretty
Hey
clear
B,
answer.
like or like something cool like B. What's B short for? Wolf, Beowulf.
Wolf. Incredible.
My youngest daughter, I really wanted to have a son and name him Bear, and my wife was like, under no situation, in any way or world, are we going to name our kid Bear? And I was
Right,
like,
right. Not allowed. Not allowed.
so she's Caroline, and then as soon as I was like, good, Caroline, perfect, Bear. And she has been Bear her whole life. And I'm like, and her nickname is Bear Star. So at least, I mean, it's like Wolf, I get it. And then
Right.
Lisa has Fox and Ren. Like her husband's a legitimate rock star. They're so cool, but Ren and Fox. And then
Love
I'm
that.
like, Kelly. And then it rhymes with Smelly Jelly Belly. Anyway,
Yeah, yeah, we're
now
perfect.
I've been vulnerable. Let's go.
Let's go. Um, is it? Do you go by Dr. Starrett? Do you go by Kelly? What do you?
You
What
can
do you
call me
do?
Kelly.
Kelly. Okay, yeah, I'm
Yeah,
Brian too, by the
absolutely.
way. Thanks for doing this, by the way, Kelly.
Oh,
I
very
might
thrilled.
might uh might fanboy out on you a little bit. I came across you when Supple Leopard came out,
Wow. That's 10 years
and
ago.
yeah, maybe a little after that. It was probably like 2013, 2014. And I just started kind of crossfitting myself and really plunged into the book and then I was fortunate enough. I'm a neurosurgeon by background, and we just didn't. The training doesn't really expose us to you guys enough in any way on the physical therapy
Both
side. So
directions. Totally
both
both
directions
directions.
probably, yeah. And so I got into spinal deformity surgery, scoliosis stuff, and it was a
Amazing.
little more like some of that research came from France, and they were a little more interested in posture, a little more in line with some of the physical therapy principles. Like the Schroth physical therapy team was always part of the conferences and stuff like that. And that was right when I got introduced to the book, and I got dove into your book. I had the benefit of my brother. I have a younger brother who's about 10 years younger, and he was a big CrossFit guy, stuck with it for a decade, got really into it, and had a background degree in kinesiology.
Mm.
So he was always in my ear, sort of chirping. So I kind of had that too, but I just kind of got really interested in it, and that was toward the end of my training. And I think it clicked because you're seeing patients every day and there's something missing, right? Like you start doing some reading and you're like, why do I
Yeah.
not even know what these words mean? Like, why is there a whole other field out there that's very relevant?
And by the time, honestly, by the time people are in your office, they
Right,
probably really need you.
right.
And
Like
so
they're
at some
done.
point, you're frustrated because you're like, hey, we missed somehow in our whole profession
Right,
100 steps before you need to be fused
right.
or have a laminectomy or, God forbid, something else. You know, I think it's really amazing. If we do this right, in the next 10 years, we should have a much more unified field theory approach.
Yep.
But it's still, my spine nerd, surgeon nerd friends,
Right,
I'm like, hey, if all positions are good, why is spondy still a thing? You know
right.
what I mean?
Yeah, like what's going what's
Like if
going
it's
on?
okay to do whatever I want with my spine under load, why are little kids fracturing their backs? Like,
Right,
is that just like they don't have enough calcium in their diet? I mean, it's just a maladaptation. So
right.
at some point I have to be like, and I really just have to, give full props to my physio school, which was heavy, heavy Maitland.
Mm-hmm.
And also we were attached to the World Center of PNF. So
Hmm.
right there at Kaiser Vallejo.
Yeah.
And then, I would say Stuart McGill, I really had this spine first approach that, hey, let's look at the nervous system as a limiting factor to all these things. And so for someone with your lens and background, you're like, oh, this really feels and makes sense because we're
Right.
always thinking about the spine as the limiting factor to function.
That's interesting. Yeah, it's a one of the things I remember from I think Supple Leopard was sort of your chapter on core strength, how the core functions, and you talk about it in Built to Move too, the squat test here, but I think there was a chapter on that in Supple Leopard and that's where my brother came into the picture too, and I was probably mid-30s at that point, and he was like, I bet you can't do a squat. And I was like, what are you talking? Of
I
course I
bet I
can
could
do
do
a
a 13
squat.
hour surgery. Oh, I can't squat anymore, put my arms above my head, but
My posterior chain's tight. What? Who says who? And I tried the squat. It didn't work. And then he educated me on that. And I've done that sort of squatting thing. I do it in the operating room.
I believe
And
it.
every place I've moved, people are like, what are you doing, doc? And I'm like, squatting. And they're like, well, are you okay? Are you sick? Because if you get students in the operating room, sometimes they'll just they'll vasovagal, they'll pass out, right? Especially if they see blood. So they see me down at squat, they're like, are you feeling lightheaded? And I'm like, no, are you? Well, what are you doing? Stretching.
Welcome to the sterile field.
Yeah,
It's a
welcome.
much bigger field than you thought. I love it.
The one of the things that I learned, so maybe I'll give you a little of my background, Kelly, if you don't mind. So I trained at like a traditional neurosurgery place at Yale, which is very cranial based. A lot of brain tumors, a lot of epilepsy. The kind of the grandfather of epilepsy surgery was there, and there were good spine surgeons there, but it wasn't a deformity place. That's not where I picked up those principles, and we really didn't, like I said, cross pollinate at all with physical therapy or sports medicine or anything like that. And then in the middle of that training, I went to the Hospital for Joint Disease, and they were working with some of the French folks with the deformity type research. And we talk about this cone of economy in balanced posture. And the idea being you're spending very little energy if your skeletal structure can allow you to stand within a basically a cone. So you can tolerate slight perturbations off perfect
I love
posture.
that idea. I see that right
and
away.
it's not mine. It's well been published for decades. But when you have a fracture or a spondy or something that perturbs you beyond the cone of economy, now upright posture, standing posture is an act of muscle strength, right? Your muscles are sort of holding the skeleton up. The skeleton's not bearing most of the load, and that creates kind of chronically overused muscles, and that's where pain scores start to go up. And a lot of the surgery, especially in this is kind of in the spinal deformity world, started to focus on, look, we don't know what we're doing right or wrong. Some people get better, some people don't. And it went back to sort of core principles, and folks said, look, I think if you can bring them back into the cone of economy, you'll have accomplished something. And so that's still sort of a guiding principle out there. And
Do you think it's still valid?
I mean, I think it's crude, right? I don't think it has a lot of granularity to it. It's
Hard
like
to be objective, isn't it?
very broad brushstrokes, right? It's like, okay, if you see somebody and they're listed way over, and that's how their skeleton positions them, and you can get them straight, yeah, okay, but, probably you're in the ballpark of doing something right. But like you kind of,
I just think like ankylosing spondylitis. I'm like, whoa, this is get you stiff in the right position.
yeah,
like
yeah,
we're just gonna eyeball it and hope you
Yeah.
stiffen up at the right moment at the right time. Okay,
right,
let's do this.
right. And then the number of people there who also have mobility issues. I mean, almost all of them have mobility issues in the hips and the hamstrings and the knees and the ankles.
And what you bring up is where and who is addressing that. You don't have time. It's not actually in your. I would say it's not in your practice. It's not on your problem list of things to work through. Is to put someone on a program to open up their hips and take some of the extension load out of their spines, like that. And I don't even think physical therapy is the place for that.
I don't think it happens there.
I don't think it does. I think we're still in, your model of, well, you're out of pain and you can get up and down off the toilet. Good, let's pass you on.
Right.
It's a wild time. I have this. I don't know if it's my idea. Maybe it's Ida Rolf's idea, but that maybe exercise is really just to retrain and hyper sensitize us to where gravity is. I mean, where is straight up and down? How do we train straight up and down?
Yeah.
And so much of what we're doing, if you look at yoga and balance and training and pressing and squatting, it's all about how do I manage my carcass and some load in gravity. That's it.
Yeah. That's an interesting thought. And in Built to Move, you guys talk a lot about, and I'm sure it's very common in who you're seeing every day, folks who sit all the time, right? And then someone like me, I think about myself personally at work, where I'm always standing but slightly pitched over a table. So it's like the posterior chain's just super tight.
Yeah.
Right? In your mind, Kelly, like when you think about those two folks, right? Someone whose posterior chain is always sort of crunched forward, and then someone whose posterior chain, auto mechanics, surgeon, beat cop, like whatever you're doing where you're standing a lot, you're not necessarily moving a lot, which is kind of a lot of what Built to Move is about, obviously. But if you're seeing you're seeing a patient, one is very sedentary, the other one is standing but not moving. What are you thinking? What's going through your mind with those two examples?
I'd say honestly, the way to think about it is almost that those are the same thing. The problem is marathon static postures. That's really tough on the body, where we start to see systems fatigue. We start dropping out of our muscle systems as they fatigue. Now you're hanging on the bony structures, right? And now you're like, okay, now it's fascial structures. Now it's ligamentous structures, right? And your body sort of alternates through, and that gets achy, and you kind of switch to these sort of different strategies of long-term static positioning. Right. And as you already described, you end up doing this deep gross flexion pattern position.
Yeah.
It sort of just resets that mechanism, just gets out of that tissue creep. I mean, that's what you're doing. You're kind of out of a sort of a, globally extended position.
Yeah.
I think a useful tool for this is to start to say, well, how do we organize the environment to take some of the loads out? And again, standing isn't bad, sitting isn't bad, but long bouts of either of those things. Let me know how your back does after a long day at the operating table. I bet the average person could not tolerate it. And if we look at cervical degeneration in our spinal surgeons, it's real. And then when your hands go numb and you're like, I don't know why, I'm like, well, look what position you've been in for 20 years.
Yeah.
Right. Plus alcohol, stress. I mean, these are not healthy environments, right?
Yeah.
So I think what we can start to say is, well, could we get you to put your foot up on something, take some of the extension loads out of your, just by bringing a foot up, one foot, 1 foot.
Yep.
Suddenly, how do we organize you in a way where you're working in a place where you're not in such wretched mechanical positions? And I think the health of the surgeon is the very last design criterion in any operating room. I mean, it really just is not, it's not designed for that. We have all this machinery, all these people, we're moving the patient around. Maybe the anesthesiologist wants the best group, So, how can we think about changing the environment so we don't have to make another decision, so that you can do your job and not worry about, hey, my back is killing me, right? You should just be able to threaten. The other thing we need to start asking is, what is going on in the other hours of the day? And a useful tool for thinking about this is something we grabbed from Premier Soccer called session cost. And session cost is when an athlete performs a big training session or as a game, we can look at the impact on their physiology the next day. And some of them are lagging indicators: heart rate variability, right? Central nervous system, arousal, stiffness, soreness, force generation, whatever floats your boat there. Yeah. And ultimately, we start to ask then, well, what are the sets of behaviors where I can drop in to somehow reduce that session cost, which may mean that I need to spend some time in flexion at home. That may mean that I need a little bit of soft tissue work for 10 or 15 minutes to just rehydrate the fascia, just to recapture those springy systems. And lo and behold, maybe as you saw, hey, I need to work on a little bit of flexion, bring my knee to my chest, and I need to get some flexion in my lumbar spine. I mean, that's really what's happening so magically when we just sit in the bottom position. We're just rehydrating this and getting ourselves out of that nutation or into some nutation and not just jamming ourselves into extension. And suddenly then we can say, well, okay, we've solved this problem in these sports. How can we start to think about the home environment as a place of restoration, not just entertainment, which is what I think we've done. Is we've said, you get home and now you just eat whatever you want and sit on the couch. Meanwhile, we're not thinking about the fact that the brain doesn't recognize the psychology, the positions as different, that you're under high stress or you've been doing something for, your brain sees that as sort of a behavior. And now what are the behaviors I can go in to sort of reset or reclaim? And underlying that, we've never given anyone any benchmarks or vital signs to say, hey, let's keep an eye on your minimum,
I love that in the book. I love the vital signs approach and like keeping it as simple as possible for folks. Like 10 vital signs, that's it. It needs to be boiled down to something like that. And you just struck a chord that just resonated in my brain when you were talking. And I'm thinking to myself here, but I'm extrapolating it out to patients. You're talking about being in a stressed or suboptimal position all day. You come home, you're kind of beat up. What I notice, and you guys had a chapter on sleep. And I always tell my patients, sleep's the first medicine, right? Like if you're not getting adequate sleep,
moly.
like you're
what a message to hear from you.
It's a good message, right? Like that if you don't have good sleep, it's not okay. And so you guys have this dietary chapter and sleep chapter. One of the issues I find as a surgeon, I'm sure many other professions find this, you come home, you're kind of amped up on the stress, right? Like there's an adrenaline element to what you've
For
done.
sure.
And I'll kind of roll out, right? Like I'll do thoracic extensions, I'll roll out my whole posterior chain. But that stress state, you naturally crave high calorie foods from the stress hormones, I think. And then you guys talk about it in the book
How
how
about this? Let me interrupt there. Likely you're highly undercaloried for the day.
that's probably
Because
true
you
also.
didn't eat a gigantic burrito and then go back to the operating room
Right.
because
No.
you fell
No.
asleep. And so what you've seen is that you're actually highly undercaloried, and then let's add in all the stress
Right.
and the self-soothing and hey, I need a boost of serotonin here and
Yeah.
all of those things. Right?
Yeah.
I think it
That's
all combines.
That's a big challenge. And then you realize what you kind of society trains you to reach for, right? You're like, well,
Oh, yeah.
hard day at work, the stress kind of, I earned something here, right? So whether it's a bucket of ice cream or whatever your kind of go-to move is. And then you got to cut through the stress, right? So everyone grabs a beer or a drink, and then that's going to mess up sleep. So now you're kind of sleep deprived. So you've overtaxed the body, undernourished the body, and now you're going to go about sort of treating that with all the wrong tools, right? So, do you guys have I didn't see this in the book. Like, what would you say to someone in that situation where they say, Kelly, I try to stick to the diet and stick to the sleep, but I find myself, coming home
Yeah.
from a long shift and I'm just
Yeah.
chowing down on
That's
chips
right.
and
So what we've tried to do is try to create some objective measures. And in Supple Leopard, remember, it's got to be observable, measurable, repeatable. And I understand the brain is the most sophisticated structure in the known universe. I mean,
Right.
attached to a physiology that is so tolerant and so complex. I mean, you can run this thing pretty ragged and still show up, especially when you're young. The tolerances get a little finer as you get older. But one of the things that we tried to do in Becoming a Supple Leopard, our first book, was say, here is native range of motion. This is the range of motion that you as a physician and I as a physical therapist all agree on. This is what everyone should be able to do with the shoulder. This is why we measured all those joint angles in school. This is what, right? You're not that unique. The uniqueness is your femur's longer, your pelvis is width, different, but ultimately we should be able to move the hip to 130 and 140 degrees, whoever you are, right? And so that was the first objective measure. And all the tools were just what I called position transfer exercises. Hey, I see that you can't put your arms over your head. That could be because your lats are tight, you don't have any thoracic extension, your shoulder's blade is glued down, we can go down the list of issues of why you can't do that. It doesn't matter. The question is, how can we restore you back to human operating system? And you see people enough, certainly, where, hey, you don't have a lot of flexion left over in your spine because your discs are now wedges. Like that happens, right? Yeah. But the other objective measure there in the book, which was just normative range in people that weren't pathological, was output, biomotor output, wattage, poundage, watts, ergs, whatever you care about. That's the thing that this expression gives you, that when we return you to full physiologic range, you have more movement choice, and we see that expressed in better biomotor output. So the objectiveness is the key. And so when we go in and try to, because what you just described is every high performance group I've ever worked with, whether I'm talking the English national soccer team, the All Blacks, the Niners, like I see a lot of dirty laundry with people who are in high performance. And I would say, let's put spine surgery as high performance as flying a jet or any other sort of tactical high risk, high daredevil thing.
Right.
I mean, hopefully you don't think of yourself as a daredevil when you have your hands in my brain, but perhaps it's an appropriate analogy. But what we start to say is, okay, when we start to look at the whole, it becomes very complex. And as you saw, all of the complex behaviors start to aggregate. One of the things you didn't talk about in that day of stress and eating and not moving and needing to calm down and feel like my human again is we didn't talk about how much caffeine you've had, and that the half-life of caffeine is 5 hours.
Right.
And that caffeine you had at 3 o'clock to get through your last case is still pumping, right? So suddenly we have, that's Adderall and Ambien. That's the dirty secrets of sports. It's THC and 16 espressos from Starbucks. I mean, we see how people are doing this. So what we start to do is say, where can we control or at least begin to understand some of the inputs into the black box? And so there is a I think he was a sociologist named Charles Perrow, who wrote a book called Normal Accidents. And in there, he calls it's about normal accident theory. And that is when we have systems that are so complex, oftentimes the processes in that complexity are so tightly coupled, it's difficult for us to see inputs and outputs. And more importantly, what things that look like crazy accidents are actually just normal expressions of the system if we give the system enough time to express itself. And I think spinal surgeons are on that end of people are like, how did I end up here with 16 bulge discs and no disc space and and all these bony changes? And well, you're like, well, you haven't slept, you drink a ton of alcohol, you haven't loaded, there's no micronutrients in the system, right? You sit in your computer, like you can just see, like it just took 70 years for that thing to finally throw an error signal that your brain, because you see people all the time who are asymptomatic with spines and nervous systems that look like trash.
Yep.
It doesn't necessarily throw an error signal until it does.
Yeah.
And so someone suddenly says, well, what happened? I haven't changed anything. And now I'm in chronic pain and I can't take a breath or I can't move or do my job or occupy my role. So as we try to work our way through that complexity, we can start to say, okay, well, what does the research say about specific baselines? So one of the things that we can start to say is, well, look, I don't care when and how you're going to do that, but let's make sure you get enough protein in for the day, right? And let's make sure you're actually getting some micronutrients and fiber in your system. And so when I set that up, when I said, hey, I want you between 0.7 and 1 grams of protein per pound body weight, and I want you to eat 800 grams of fruits and vegetables. That's 4 apples. You're a big boy. You went to med school. You can eat 4 big apples a day. You're just going to have to work it out when that is. Suddenly you're vegan, you're Indian, you eat lentils, you're Latino and you eat beans, you're Irish and you eat potatoes. It doesn't matter. All those things count towards the way. You're vegetarian, you're carnivore. I don't really care. Show me you can get your protein minimums and show me you can hit your fruit and vegetable fiber minimums.
Right.
And suddenly we have a ton of calorie control built in. Suddenly your soft tissues and connective tissues are getting what they need. Your gut is getting what it needs. You can rebuild, right? And suddenly we start to normalize inputs and outputs because we start to make sense of this noisy data stream.
Right.
So when I make you start to track your sleep, legitimately track your sleep, and you start to see what gets measured gets managed, and you're like, holy moly, I had that cocktail, and then it wrecked my deep sleep. Then maybe you say, I'm only going to have a cocktail when I have a few days off, when I'm rested, not when I'm stressed, right? We can almost look at, especially since we're talking about, with a spinal surgeon, neurosurgeon, almost can look at things as tonics to the nervous system and as stressors to the nervous system, for lack of a better, dichotomy there. Right? Sleep, but alcohol is a stressor. No sleep is a stressor. Shitty food is a stressor. So what I start to say is, depending on where you are right now, you're going to be able to handle more or less stress. That's no different than my elite athlete or my Olympian. How much volume can we handle and still manage a baseline? But when we start to realize, wow, you actually haven't taken a big breath, you haven't moved your body enough just to decongest your tissues, just to move the lymph through the lymph channels, just that alone, you haven't hit that. Suddenly we start to see that we can start to make more sense of what's going on. And I think then what we see around that is we see that each one of these kind of keystone behaviors sort of has a set of valences around it. And those valences end up sort of organizing some behaviors. So we start thinking about your sleep early in the day. Am I getting enough? I messed around. Here's an example. I messed around with intermittent fasting. I think a lot of people did. What we call now internally calorie control for adults, right? It's really like, here's a sneaky way. I'm not really hungry in the morning because I've had coffee and let's go. And then I'm suddenly like, I can not eat till 12. And look, I just saved all these calories, right? Meanwhile, when you work out in the evening or in the afternoon, you have to do something physical with your body like surgery, you're under-fueled, under-caloried, your performance sucks, and then you get home and you're deeply under-caloried, so now you overeat. And then I had this moments where I'd be like, let me eat this chicken and this jar of peanut butter and these 5 cookies. And then I'd go to bed on that stomach full of food, and guess what? My sleep was terrible. I'd wake back up and be like, let's intermittent fast again. So what I found is I wasn't hitting, again, my minimums suggested by the research, suggested by our clinical experience. And when I started to do that, then I realized I would be clever enough to work in the details around those moments where I did have some agency. So if we're talking about it, one of the things every surgeon could tend to do, what would help their body with physicians, when you get home, you're probably watching some TV for a few minutes or answering emails,
Yeah.
sit on the ground
Yeah.
for 30 minutes.
Yeah.
Suddenly, I've just put in 90-90, some hip flexion, some long sitting,
Yeah.
right? We're loading up those tissues beyond positions, and it's all happening in the background. And then I'm
Right.
like, oh, I'm already on the ground. Hey, there's my roller. Let me just see if I got 10 minutes. Like, you started already creating an after action report. If I don't do these things, I'm going to feel not as good. So you came home, you created a little routine, which is exactly right, which is actually no different than the work we've done with Black Hawk helicopter pilots who come in after a mission, turn in the machine, and then are like, man, I've been wearing nods and body armor and I'm in a terrible position. I'm going to have to make sure that I can reduce that session cost.
Right.
And so
Yeah.
suddenly now it becomes, I think, a little bit easier to wrap our heads around what's essential. And in this situation, performance for you is not burnout, fewer mistakes, more energy for my family, more energy for myself when I get home.
Yep, absolutely. I mean, it's funny you were talking about body fluids. If you'll stand, some of these surgeries are 10, 12 hours, and if you stand there that long, not surprising to anybody who knows this stuff, but your feet are swollen, right? I remember being struck by this. I'm like, oh, my feet are swollen, and you'll start to get varicose veins, and you're like, I'm a healthy, fit guy. Why do I have varicose veins? Like, well, the fluid just pools, right? These are two tree trunks that don't move, and you pooled the blood and all the toxins and everything else, and it's not circulating as it normally would if you're moving around and changing your position.
Right.
And
You've got cankles.
yeah, right.
Surgery-induced cankles. And
Yeah.
anyone who's ever flown on an airplane, if you've experienced this congestion, what you're seeing is
Yeah,
it's
you know
just
that.
not enough. I mean, that calf, they call it the second heart for a reason,
Right.
That venous return. And if you're not squeezing your muscles, you're not returning
Yeah.
that venous return, and you're not moving that lymphatic fluid through.
Yeah.
So the question now is, okay, do I put myself on dialysis before I go here? Am I,
Right, yeah.
I mean, like you start playing this like, well, I'm a physician.
Yeah.
Let me heal myself with this diuretic.
Yeah, yeah.
Or now we're like, okay, in between, we need to make sure that we're in cases. I need you to get a walk in.
Right, yeah, yeah.
Or the second you're a break, it can't just be a break. I need you to just move your body a little bit.
Right.
What does that look like? It just
Yeah.
may be a couple laps. Or we may need to add in compression hose.
Yep.
And when you get home, because we can't, at some point, sometimes it's impossible for us to manage all of the considerations of the job.
Yeah.
And I think as a young physio, I was like, we'll just, and then I was like, oh, okay, you're a bus driver, right?
Yeah.
You're driving a tank. You're flying an A10 for 16 hours and
Right.
peeing jugs. I mean, like, it's not a great place to be. So suddenly we say, okay, well, how do we just minimize session cost? Because we can't possibly account for all the things based on the way the world is set up.
Right. And the hydration issue is such a hard one to break too. You know, that we were talking to a cardiologist and he was giving us the ounces numbers. I think he said, I'm going to butcher this, but I think he said roughly half your body weight in ounces, something like that. And we were doing the math, and there was a teacher in the room, and he said, and the cardiologist asked him, would you say you roughly drink that? And he says, no, I have 2 cups of coffee in the morning, and then I don't leave the classroom, and I stand at the head of it all day long, and then I come home and I have a beer. The cardiologist was like, what?
Nailed it.
What? Yeah.
Landed the plane. And suddenly you're like, oh, you would survive on Arrakis with
Right.
under strict water rationing. But that's not so far from the truth, right?
True.
And
Totally.
so suddenly, what if I came into your operating room and you come out and I've got minimum amount of food I need you to eat. I've
Right.
got minimum fluids that you need to take on
Right.
so that you can be ready to go. But that's not how we're thinking about like this sort of, aid station approach where we're
Yeah.
saying because the problem is you can get away with a lot for a long time and
Yeah.
then something doesn't work.
That's
and
right.
I'll tell you what, just be hypohydrated consistently, throw in a bunch of caffeine in the system, your tissues start to become less tolerant. They
Yeah.
don't handle the stretch and static. Now you've got this fascial issues.
Yeah.
Right now your neck hurts. Now we're now down the rabbit hole of
Yeah.
how do I self-soothe so I can do my job? And now
Yeah.
you're no different than anyone else.
Right.
So this is where we have to start really thinking about any population, where do we have agency?
Mm-hmm.
And where may mean some prep, but what I want to do is take out all of the other sort of willpower, because if I'm like, all you have to do is go down to the cafeteria, you're like, I don't have time to go to the cafeteria, so that behavior's gone.
Yeah.
Right. Unless it's set up for you there as you're dictating your notes right after surgery,
Right.
it's not going to happen.
Right.
So that means, where are the steps and before? Well, on Mondays you have to bring in a whole bunch of protein shakes and,
Yep.
and have element and hydration ready to go, and you have to think differently about how we're going to care and feed, because the demands are so much higher now across almost every domain of high performance. We're seeing, I mean, you know, my mother-in-law is going in for a hip arthroplasty, and you know, that surgeon's had 126 surgeries booked already. You know,
Right.
at Kaiser, just
Yep.
on the books, just working through the list, and the
Yep.
list isn't getting shorter.
Yeah.
It just continues to be stuck at 126.
Right.
You know, which is, so what I suddenly say is, well, and I ask this in a really tongue-in-cheek and also horrific way: is it going to get better or worse?
Yeah.
Are you going to do fewer surgeries or more surgeries? You know.
Yeah.
And I suspect we're trending in a direction where we're going to do more surgery.
To do more surgery, yeah. Yeah, I mean, that something you said in there resonated, where you can do it until there's this threshold phenomenon, right? And that's true with the pathology we're treating too. People always come in and say, how was I fine?
Right.
You know, if this is a chronic issue and this is arthritis that's developed over my lifetime, why'd the problem only creep up, last month? And you say, well, you were fine until you kind of walked over the threshold. Now you're not fine anymore, and now you have a problem. And that is, it's not, I wouldn't say all the issues I deal with are preventable, but when you've done nothing to prevent them, right? And one of the things that struck me about, and I think you went into this in Supple Leopard, the fascial tissues, the soft tissues that people really aren't thinking of, right? They're not thinking of the tendons. They're not thinking of the fascial layers. They're not thinking of the friction between the tissues. That's real, and the surgeons know it. You get in there, you physically look at it, and it literally looks like a rubber band, right? Nice brand new rubber band, stretches like Gumby. It's all over the place. Old crusty rubber band, you move it too quick and it snaps. And that's what every layer of the tissue looks like, and the more old and immobile it gets, the more tight and brittle it gets. And that is left out of that thought process. That as that slowly collapses in and ankyloses and stiffens up, that's building into your wherever your threshold's going to be for you, right? Whoever the person is, if that's 55 and you pop an ACL, or if that's 62 and you have a back issue, whatever it is. It's gone undetected for 35 years, whatever it is, because you can't see it. You don't think about it.
It's that normal accident theory, right? It's just,
yeah.
The valve snapped off at the nuclear power plant. It's not a problem until it becomes a problem when we need to open that valve to do something, right? And well, it wasn't an emergency situation. And then when I say that, I mean, maybe you could tolerate that when you had this amount of sleep, and you could tolerate that until you didn't have this amount of stress, or you can tolerate it until, you can tolerate a lot until something is a triggering. And it is difficult to stop that central nervous system bell from ringing. It's a lot easier to say, okay, how are we going to think about minimums? And I think when we wrote this book, we simultaneously were trying to recognize and give honor to the fact that the fitness industrial complex is $1 trillion industry.
Wow.
And it's not solving obesity, diabetes, chronic pain, surgeries, opiate. It really isn't it's not doing anything it's purporting to do.
Right.
We have sexier abs on Instagram.
Right.
That's what we've done, and we've left everyone else behind.
Right.
And simultaneously, we saw in the pandemic that we had failed to teach society how to self-soothe. We saw people gained weight. We saw substance abuse go up. Why? And remember, that's people saying, well, I've been trained to self-soothe with food, and I've been trained to self-soothe with booze, and whatever it is that's around. Let me go ahead and just reach for the tools that have always worked for me. And what we hadn't done is really said, if I go see my physician for a physical, they're going to look at a few blood markers, hopefully.
Yeah.
And they're going to look at, heart rate and blood pressure and some other things. Those are valid vital signs that everyone understands. They're a little bit lagging, right?
Yep.
I mean, my blood pressure sort of tells me about all the things that have been happening.
Yep.
A1C maybe is a little bit better, but what we hadn't done was said to people, hey, 120/80, that's just fine blood pressure. It's not good. It's
Yeah.
just average. But it
Yeah.
lets you know, here's the delineation where we should start to pay attention.
Right.
And when we took some of these essential physical health behaviors and assigned minimums, red, yellow, greenish,
Yeah.
then it allowed people to say, oh, hey, this was really tricky. I haven't looked at this for a while
Yeah.
because my life has been demanding these other things. And that, I think, simultaneously is interesting for Juliet and I, because we feel like the 10 essentials here are still the small hinges that open the big doors on performance. So if I come in and working with the world's best surfer, I'm working with the world's best something or other, I don't miss these things. I am investigating sleep and stress and nutrition and all those things. But also we realize that, man, we're not really having an honest conversation with people about what is essential for the care and feeding of the body, especially as we're now becoming hyper focused on living to 120, 130.
Yeah.
Because as you know, when that movement hallway starts to become narrow,
Yeah.
man, your movement choice, the quality of life, the things you get to do, the role you occupy in your family, your job, suddenly we start to really restrict choice, and your quality of life isn't great. So how do we maintain that and build in some, I'll tell you, I had my knee replaced after having a really traumatic ski accident. I booted out going really fast and ended up putting my femur into my tibia and had two kissing gigantic bone lesions, but did not have a tibial plateau fracture. I just imploded the meniscus, kissing bone lesions. Managed it for a long time. Finally went in, and what was interesting is they went through 3 saws to cut my bones, right? They could not cut my femur. The saw would just smoke. And the resident was like, what's happening here? It's not cutting the femur, like get a new saw. And when they cut my capsule, I was highly vascularized, and my capsule just bled and bled and bled and freaked everyone out because they were seeing all these tissues that didn't have all the capillarization.
Yeah.
And I'm pointing out that I'm just an average guy who has been training and moving and trying to do these minimums for a long time. I'm not a super mutant. I was like, what happened? What's your strategy for my super mutant friends?
Right. Yeah.
Who have adamantium bones. I just
right.
have middle-aged deadlifting bones. So, I think one of the things we're trying to do is also recognize that catastrophe is going to happen to you. It will strike you.
Right.
Someone's going to get breast cancer. You're going to get hit by a car. Something is going to happen. What kind of material am I bringing to my surgeon so I can say, hey, give me the best chance. I've brought you my best. And I think what we're asking of our physicians right now is not really equitable. We're bringing a dumpster fire, and we're like, all right, put me out, put me back. I don't want to change anything. Make me better with this scalpel. And that's a really unfair conversation.
Yeah, that's tough. That's really tough. This is interesting in the introduction. I think you guys talk about this. Correct me if I'm wrong, but I think anybody in clinical practice sees this. You'll see these folks. Some of them are, 72 is not 72, right? Some people are 72 and it's the walker and granted, sometimes life threw them dealt them a hand and to your point, maybe they're cancer survivors and it hasn't been going well, whatever it is. But if you take an average 72-year-old who's healthy, and let's rule out other issues, some of them don't look like the others. And one of the things we always are taught as surgeons spine surgeons, is life is a kyphosing event, right? So you're constantly pulled down. And then life is also an ankylosing event, so the stiffening, everything's stiffer. But
I will quote you on those two things for a long time.
I don't even know where they come from. So you see these folks, and that's been my observation. You guys mentioned in the introduction, when I see them, it's like there's always this, you're more kyphotic, you're more ankylosed than the other 72-year-old. I'm just picking that age because that's kind of that transition age, right? You better be good by the time you get to there. And it's a stiffness and a hunched kyphosed posture. Let's say someone like that shows up to you guys, and they are 72, right? They're 72 years of stiffening and kyphosing. Where do you even start with that, Kelly? Like, because that's kind of what we're faced with, right? And they want to know what their surgical options are, and not all of them should have one, right? So you say, look, this isn't a surgical issue. Like, it's a much bigger issue, actually.
Yeah. If I was working with someone in that situation, the first thing we actually start with is the first movement of the spine, which is the breath. And what we find is, man, I potentially have 10,000 opportunities to tell the brain this position is safe because I'm taking 10,000 breaths a day at least. I have a way of restoring, plasticity and dynamic movement through the rib cage.
Yeah.
I have a way of sort of dissociating diaphragm from psoas, right? I can start to pump lymphatics through.
Yeah.
I can change CO2 tolerance and VO2 max by changing respiration volumes. And we always start there because that is, no one's going to die breathing. We can do it in the bed. We can do it when people are super sick. We can do it when they're not very mobile. Even in chronic pain, our first intervention when people have really bad low back pain flare-ups, we teach them to get their brains under control through their breath and also restore a ton of this motion to that system that may be stiffening on purpose as a strategy, right? So, but if I just go ahead and beat the crap out of your T-spine and you don't know how to move it, or you never use that later on, that's an issue.
Yeah.
So suddenly we start to ask, well, now what are the minimums? And an easy way of starting to think about that is, well, what is the shoulder supposed to do?
Yeah.
The shoulder should be able to put my arms over my head. Okay, I should be able to put my hand behind me, whether it's elbows bent or elbows straight. Yeah. My hand has to go out to the side, and it has to go in front of me. That's all the shoulder does, people. It rotates and the elbow bends, but people are like, the shoulder's so complex. I'm like, it does like 4 things. And so just chill out a little bit. I mean, there's some high tension wires that are pretty cool in there that we have to respect. But really, when one of the things that we can start to do is say, instead of kind of throwing our hands up and saying, oh, there's too many things, we need to start by asking, well, what are the movements that are allowing you to express these fundamental shapes? And I call these archetypal shapes, right? The same way, well, what does the spine do? It needs to flex, it needs to extend, it needs to rotate, it needs to side bend. Most of the time, all of those motions are happening at once, right? That's why assessing the spine in some very cardinal planes is useful, but doesn't really tell us about locomotion. Same thing we can start to say, though, at least, hey, I see that you can't flex or you can't rotate. Let's become curious about how we were going to restore that. But more importantly, what are the movements? So suddenly you jump into Qigong and you're like, oh, they spend a lot of time working on internal rotation of the shoulder. Like, why is that? And suddenly you go to yoga and you're like, man, these people are obsessed with downward dog. Why do they think that I got to put my arms over my head like it's my job? Like, this is crazy. And I think what we start to see is in some of our movement traditions, we are hinted at, these are essential practices that allow us to maintain or at least touch native and crucial ranges of motion. Right. So yes, my grandmother may not be able to hang from a bar her first day. Right. But it may be that she needs to wall crawl up to a position where she's limb limited. Yeah. And then take 10 breaths there. Yeah. That's what we do. Or she's on her back with a stick and we're working on thoracic extension over a pillow with a stick as she breathes there. Now we can start to really have an intelligent conversation of what's the dose? What's the frequency? Yeah. That's the art of this thing. But what we find is, man, if I'm going to come in and really have an innate, legitimate conversation about your ability to move in the world, and you don't have a plan to actually touch those things, that's like coming in for a vitamin infusion and then just living off pizza. I mean, you can do that, but it's a pretty austere life. Like, I don't recommend it. Colorectal cancer will not be your friend. However, suddenly what we realize is, again, we're back to the environment, and we need to make sure that we're shaping the environment to at least remind us to use our bodies in these native essential ways. If you don't have internal rotation or extension of the shoulder, that shoulder is going to drag you and now be another load of kyphosis. Yeah. And I'm never going to get you out of that kyphotic posture unless I simultaneously work on your thoracic spine and restore your shoulder function. Yeah. That's why we look at the shoulder and we look at the neck and we look at the neck and we look at the shoulder. I mean, so and what you just hit on again is this the physician's responsibility? It may be the physician's responsibility to say, this is my movement specialist. This is my lifestyle person that you're going to meet with 3 times a week for an hour for the next month to really start to get this out. And then we can reevaluate if you're a surgical candidate or not, because Right now, I'm like, what are you doing?
Yeah, right. You can't even make a decision. You can't evaluate
You
appropriately.
haven't extended your hip. You haven't taken your hip into extension in 20 years. So if we fuse you, I mean, okay, we can do that, but you're
That's
still not going to be, extending your hip.
one of the so without getting too down the rabbit hole, spinal deformity surgery is sort of this. I don't know what the right word would be. Super specialty, I guess. That
Yeah.
sounds like I'm patting myself on the back. It's not meant to sound like that. It's just uncommon, right? Only a smaller number of spine surgeons will do deformity work. And one of the most common deformities is to lean forward. So I hadn't seen too much deformity as a regular training. And when I moved into that subspecialty or super specialty training, one of the things they have people do is get up on the table and you're checking them for hip flexion contractures. And almost all of them who are kind of crunched forward as a result of deformity have these hip flexion contractures, and you see it over and over and over, and it's like, holy cow, go home and start checking my own hips, and sure enough, used the Supple Leopard book and was working on that hip opening move.
And the couch stretch is basic hip extension
I don't even want to
for
tell
this
you.
reason.
I don't even want to tell you where I am on that stretch, man. Like I've never really gotten any better. I wish I could say I did, but I still do it. But I mean, that's just one of those things where I'd gone through most of the training, and that wasn't part of routine physical exam. And then this small niche of people, right, who do this one thing, we're like, oh, everyone gets on the table, and you look for, and they're everywhere. And it's like, yeah, that's probably not just in that population, right? I'm sure you guys are evaluating people that aren't, crunched over all the time, and you're still finding super tight hip flexors like that.
We see the body reflect conditioning and patterning and training by the environment.
Yeah.
Every once in a while, there's something pathological pops up. But really, if we look at, let's just take Julius Wolff as our example, Wolff's law of really, that's just about the bone. But you can just expand that out to 30,000 feet and be like, the entire body, the entire nervous system is an adaptation machine.
Yeah,
I
totally.
am perceiving the environment and making changes to my structure. I mean, what happens. I mean, people come in, they start to change their movement patterns, they start to change their movement behavior, they start to change their nutrition, and on radiograph, they look like different people.
Right.
Their bones reshape,
Right.
things start to remodel. It's a lot harder to start to induce those things, right, consciously to make that change, right? People are like, I've lost height. I'm like, I don't know. It's so weird. Why is your head 17 feet in front of your body? What does that have anything to do with it, right? We have a really tall daughter who's almost 5'10", and one of our friends, he's like, oh, tall girl posture. And, she doesn't want to be so tall sometimes with her friends. And we're like, and so now she's realizing that like being 5'10" is like, as a water polo goalie at age 14 is like a superpower. Right.
Absolutely.
But, again, I think what's interesting about these conversations is they get distilled down to this is good posture and bad posture. And the physical therapists will say things like, there's no such thing as bad posture. And what I have come to try to take their, that statement and, Jedi mind trick it around to a different corner,
Right.
is say, well, there are postures that cut off my access to physiology. There are postures that make it. So if there's no bad posture, but I'm in a kyphotic posture where I can't turn my head, what I now say is, well, that's a less effective posture,
Yeah,
right? That's
sure.
a posture that's challenging tissues or challenging movement or making. So why not always teach to the highest expression of what's possible for the human?
Yeah.
And as you're seeing, we have to now be thinking, where's the functional unit of change? It's got to be in the household.
Right. Yeah, I mean, I think that was always interesting to me when I get this question a fair amount where people say, and we talked about it with surgeons, anybody, maybe a jeweler, somebody who's just looking down, right? Probably plenty of programmers and all that thing. The amount of neck disease, and as you get older, you get a truly compressed spinal cord. Your hands start to go numb, and you need to have it fixed. And they say, do you think that's my job? And you say, well, look, there's actually a condition in the textbook called welder's neck, because almost all the welders with the 40-pound head mask looking up like this welding, like when they come in, and we have a welders union nearby, those, they're 50, and the neck is ruined. I mean, the whole thing needs to be reconstructed. There's no way around it. The spinal cord's compromised everywhere. Then, you pinch the nerves, the biceps and triceps start to atrophy. It's just not something you can leave. And it's like, do you think it's really? Absolutely. It's been called welder's neck for 80 years. I mean, that's been well documented, and all that is relating it to a profession. So of course there's a posture and usage element that undoubtedly drives this kind of advanced arthritic disease. There's no doubt about it.
And I want to ask, where do we own that health problem? Where is it? If the physio message, because they're worried about fear mongering, legitimately, like if you want to trigger a whole bunch of physical therapists to say the word text neck, and they're like, there's no such thing. People are bending their heads forever. I'm like, okay, that's cool. Yeah. So by the time I have a whole bunch of little old people bent over at 90 degrees, and you said it was okay and didn't matter, is that still true? And so that's one thing I always want to try to say is, when I'm evaluating a technique or a school or a thinking or a strategy, I always ask, does this thing scale? Can I regress it, right? That allows me, or can I progress it? Does this posture and this movement, remember posture is just position in Latin, does this position get me, to the Olympics? Yeah. And does this position hold up my big head through my lifetime or not? And what you suddenly see is, well, not all of those answer those questions.
Right.
And so now we can start to have a legitimate conversation of saying, yes, of course it's okay to, binge on Netflix for a while, but maybe into the long term, that's a behavior that's going to cut off your movement options. And, one of the things that I think is interesting to me, talking with surgeons who are really seeing the sticky, gnarly endpoint of a lot of choices, right? Mm-hmm. Hey, my hands are dead knock in the doc. Hey, I don't want to have surgery. I don't want to do drugs. I'm like, well, I've never met anyone who wants to get on pain meds. So just, we're with you. But, those welders suddenly look at the nutrition, look at the stress, look at the sleep. And I just say my tier 1 military, tactical warfighters wearing helmets and nods in terrible positions in helicopters, sleep deprived, hyper stressed, right? Crap nutrition. Suddenly, all of those behaviors that we thought we could get away with accelerated, or at least eroded some of my tolerance for that stuff. And and that's where I think we start to see, if we add in genetics, suddenly we start to see, why is this person like this? Well, we can start to look at some of their lifestyle behaviors, and we can look at their genetics. We can make them more reasonable. That's why you got bit by the snake and you did not.
Right. Yeah. Fair enough.
But where are you going to have that conversation? In your office in 6 minutes?
Totally.
I mean, the physical therapist is not going to. She is not going to. She's not being paid for that.
Right.
She's not being reimbursed for that. So where does that happen? I think that's the really interesting conversation here.
That is an interesting conversation. It's completely unaddressed. There is no kind of wellness element to the whole process, right? We're here for you once you're broken down, basically.
Yeah, and we're really good at it. It's amazing. I can do whatever I want on this knee.
Yeah, right.
It's bananas.
Yeah,
backflip, ski, run, power clean, deadlift. I can do whatever. This is crazy.
I wish I could say the same thing about the backs and the necks. We don't have the back replacement quite yet, but we're working on it. Kelly, I wanted to ask you, kind of just for my own curiosity, when because in my mind here, you're doing your thing. I think you had the mobility WOD at the time, and you stopped to write Supple Leopard. Like, what was the impulse to write that book? And then 10 years later, more than 10 years later, you and your wife kind of stopped to write this book. So, just as someone who in clinical practice, what was in your head when you said, I'm going to sit down and write a book, man. I'm going to put this all out there. Is there something that drove you to that? Did you always know you wanted to do it?
Glory, tens of dollars. One of the things that I'd say my only decent skill, I probably have 2 skills. One skill is pattern recognition. I'm pretty good at pattern recognition. If you give me, I get to watch you work for a month, I'll pick up so much. Relationships, why things are done, just how I try to understand what I'm seeing, right? And that's always been the case, how I've learned skills. My other pattern recognition, my other skill, my wife would say, is I'm probably just an average, middling physical therapist, but I'm really good at giving people permission to like trust their bodies, right?
Right.
She's like, you're just like a magician in terms of the psychology of physical therapy.
Right.
And one of the things that was happening was I was a physio, came out of a very good spine first Maitland heavy manual therapy school attached to the World Center for PNF, as I said, at Kaiser Vallejo, where we're seeing very complex things. And then simultaneously, I'm running a gym with average people, right?
Yeah.
Who are now being asked to manipulate kettlebells and dumbbells and barbells. Mm-hmm. They're having to do basic gymnastics and body weight control. And only things that weren't super natural, but just asking them to express full range of motion. It's really difficult to press a barbell over your head if you're missing shoulder flexion.
Yeah.
If you can't create rotation at the end range of flexion.
Right.
And suddenly I was like, whoa. I can see all of the things going on. And so suddenly the strength and conditioning for me wasn't about, can I add another kilo or shave another second off the time? It was, are you able to maintain this position under these foundational or fundamental conditions? Speed, load, cardiorespiratory demand, metabolic demand, competition, right? Task variation, block practice, random practice. And what I realized was what we were really doing is saying, here are the fundamentals of what a body should be able to do. Hinge, the dorsiflexion of the ankle has to be expressed. You have to be able to take that hip into extension. All we're doing is taking all the shapes that the body is able to curate, and we're training those shapes. That's what formal strength conditioning is. And if you come into it, you look at Olympic lifting, you're like, all the shapes are managed except for shoulder extension. Oh, that's why they bench press. You're like, okay, I got it, right? So because that's the only position that sort of isn't represented in that.
Right.
And so what was happening at the same time was I'm in this clinical practice. I'm seeing this. We're putting the plinth very far away from the squat rack. And when someone came in to see a physical therapist, in that interview, I'm really trying to understand what's going on, but I don't really understand how someone's moving because I have a carpeted floor and a hung ceiling. Someone can't put a barbell over their head. Can't see what they look like fatigued. And so I started to recognize there were fundamental patterns of the body. And really, supple leopard is sort of a unified field theory. It's a model, just a model, everyone, for understanding complex human movement behavior. That's it. Looking at start position, looking at finish position, how do those techniques of training map into the physiology of the human for better expression?
Right.
Close pack position of the joints, subtalar neutral arch, like all of those things start to come and become relevant. And what we realized was, hey, there's probably a lot of things people can do for themselves before they need to see a physical therapist.
Yeah.
And what we tried to do with supple leopard was, let's turn the exercise into a diagnostic tool. So every time I train or move, it helps me to understand what's happening in my body. The session cost, the stiffness, I'm running, whatever it is. We're trying to train and retrain the body every day. Get to reclaim my hip function. And all you have to do is run a marathon, jump on a red eye.
Yep.
Let's look at your hamstring range of motion. You're going to be terrible the next day.
Yep.
So your range of motion and access to your physiology is very much a moving document. It's a living, moving, breathing document. So what we're doing when we're training is we're really looking at quality of positions and understanding and restoring and training and understanding we've exceeded the limits of your ability to maintain this position because we've gone too heavy, or you're breathing hard, or we added speed and all of a sudden you can't control this. Your knees are going wow all over the place. So what we realized is we had all these variables, and that was why I had a model, and I suddenly was like, hey, I think I can solve a problem. That's why we wrote Supple Leopard and becoming a Supple Leopard, to try to solve a problem by showing people that they possessed a lot of tools, which meant we had to bring the physical therapists and the physicians into the conversation of movement, and we had to bring the coaches into the conversation of healthcare because they were the place where people were spending 3 to 5 hours a week. So that was the initial impetus.
And then, so if the audience looks at Supple Leopard in that framework, which I love that kind of contextualization of it, Built to Move is sort of like you guys evolved your thought process over another 10 years and kind of took what you've done, took that model, and this is a way to kind of deliver a usable
Yes.
lifelong kind of everyday version of that? Is that kind of, am I butchering this or?
No, I think what you might see is that we wanted, if I hand someone Supple Leopard, their eyes glaze over unless they're a nerd.
It's like a textbook, right? Yeah.
It is
yeah.
a textbook.
Yeah.
It's a 450-page textbook.
Yeah.
And
It's on my
dense.
coffee table.
That's right. You should stack your computer on it and put it in your freezer. And then when something hurts, put it on there, right? So,
but I bet a lot of people use it like a reference book, right? I'm
yes,
like,
right.
So this
and
is,
it should be. Hey,
yeah, right.
You're right. I'm running into a problem. How can I solve this?
Yeah,
and
right.
again, real systems thinking there, right?
Yeah,
We're thinking
yeah.
in terms, is this a joint problem? Is this a nervous system
Yeah.
problem? Is this a... Built to Move is the prequel to this book because in Supple Leopard, it doesn't tell you what to eat, how to move, what
Yeah,
the
totally.
other days are. It's really about the diagnostic tool of the training session and understanding high-speed, complex movement behavior like running and sprinting, Olympic lifting, gymnastics. And so what we're able to do, though, is still say, hey, let's sneak in some movement range of motion minimums.
Yeah.
And so we open the first test in Built to Move is the sit and rise test. Can I get up and down off the ground?
Yeah.
Sitting crisscross applesauce.
Failed that.
And people, come on, you've done that 10,000, 20,000 times since you were a little kid.
Yeah.
And it's a very mid-range hip range of motion. Doesn't require full flexion of the hip, full flexion of the knee, any dorsiflexion, and people still struggle with it.
Yeah.
And what I realized, or I think what Juliet and I realized, was that we had spent over 10 years trying to make range of motion cool and relevant.
Yeah.
But until we showed people how it limited their ability to move doing these simple day-to-day tasks, we still hadn't sold it. Because I'm still like, why are you so stiff, bro?
I will say, when I mentioned my brother, when he said you can't do a squat, and I tried it, and it was probably 35, 36, like whenever you kind of, you leave that 20s period, you don't recognize you're stiffening, and I'm like, of course I can do a squat. And then just in a bar in the middle of the night, I try to get to a squat position and realize I can't. And all these alarms go off, right? You're like, holy crap, like I can't physically achieve this position. This is unacceptable.
How am I going to poop in the woods?
Right.
How am I going to have dinner in Thailand?
This can't happen. This can't happen.
And I think what's shocking is a lot of this physiology decays, disappears, erodes, becomes latent in processes that are hidden from us.
Yeah, definitely.
We don't realize that's going on.
Definitely.
And so what we can start asking then is, well, what is essential? Well, if I have you sit on the ground while you watch TV tonight, I'm going to go up and down off the ground once.
Yeah.
I'm going to touch some positions for
Right.
a sustained period of time where at least we can just keep an eye on it. And I think if you dropped into sun salutation in yoga, it takes like 10 minutes, they touch a whole lot of positions in sun salutation. There's a breathing practice in there. There's hip extension. There's flexion. There's spinal movements. And suddenly you're like, oh, okay. Someone was thinking critically about the care and feeding of the body. So even if we have something now, I tried to create sort of an updated version of those things.
Yeah.
So I have something called the hip spin up and the shoulder spin up. And I basically walk into environments and I say, hey, you're going to do one of three things every day in the morning. I either want you to do the hip spin up, I want you to do the shoulder spin up, or I want you to do a breath practice. Entirely up to you. 10 minutes. We're going to do one of those things. Your dealer's choice. But if you didn't move your body the rest of the day, at least we had touched some truth.
Something,
We hit some
right.
micronutrients. We exposed your ankles to some full dorsiflexion, right?
Yeah.
At least some of those things were touched a little bit. So how do we think about that? Again, thinking about, for me as a coach, how can I get people better prepared to receive my coaching? Just like you as a physician, how can I get people ready to actually benefit from my medicine and my intervention?
Right.
Where does that happen? Well, it's much more incumbent on me because I potentially am getting 3 to 5 hours a week with this person.
Yeah.
Why haven't I taught them to at least touch those shapes and positions?
Yeah.
That's maybe what warm-up is before your run. You love to run. That's super cool.
Yeah.
Maybe you have to, just do some squats, not for fitness, but just for range of motion before you run. And really, as I've gotten older, I turned 50 this year, I've become a lot more agnostic about the way you want to move. I think 10 years ago, I'm obsessed with performance, and if you can't, triple body weight deadlift yourself, you're nothing. You should be ashamed. You can't snatch your body weight. Who are you? And now what I say is, hey, I love what you're doing over here. Let's just take that into this third-party validation and to make sure that, you're keeping an eye on your minimums, because I agree that your Zumba class is awesome.
Yeah.
But you really haven't touched some of these foundational positions. Let's just give you some reference ranges.
I don't know why you reminded me of this guy, but there's like Netflix right now has a Arnold Schwarzenegger like biopic type thing.
Oh yeah.
And now it's him as an older man, and they're interviewing this guy who beat him in like a Mr. Olympia or something, and as an older, they're both old, right? And there's some comment Arnold makes to him because he lost to him, and he says, "I can't believe I lost to this guy with chicken arms." It's like both of them they have footage of the guy who's recounting. He's like, no, his words. He said I had chicken arms, and then they flash back to him, and they're both enormous, right? But it's like back then, it's all totally different threshold, totally different bar.
Third-party validation for your chicken arms, right? And I think this is an interesting issue where we need to ask, who are the stakeholders here? And what we haven't done is empowered people to understand it's actually on them. And we can't, look, food deserts are real.
Yep.
Socioeconomic class stresses are real. Mm-hmm. And underneath that, though, is still wonderful opportunities to say, hey, this is independent of how much money you have. It doesn't, there are great thinkers out there writing books around longevity that don't scale,
right,
that are talking about interventions that I couldn't run across 1 million people.
Right.
And so again, part of, I think one of the things that's been really important to me is to say, does this scale across cohorts?
Right.
Does this hold true at 70 as it holds true for 10?
Yeah, that was an interesting part of this book, definitely.
And I'm much more interested in those conversations. And trust me, get a colonoscopy. I think that's super cool.
Yeah.
But I'm not sure 4 a year for the average person is doable.
It's reasonable. I know we're short on time. I wanted to ask, for our patients, anything, I don't think so, but anything in Built to Move, someone who has had reconstructive back or reconstructive neck surgery, would you have any cautionary steps if they were to kind of, take to the book? Anything where you'd say, look, maybe don't, looks to me like all of it would be totally appropriate.
Yeah.
Yeah.
What is amazing is that, or do we ever say to someone, don't put your arms over your head again?
Yeah.
No.
Never.
No, never.
Yeah.
And so, because we've created this in such a way where we've given some simple mobilizations, we've got foundational breathing practice, I think what people will find is that it helps turbocharge their rehab experience.
Yeah.
And the other thing that I think we have a real opportunity in medicine, particularly around surgery, is that people are discharged when their insurance runs out, or you've hit 12 weeks and
6 visits
now you're
for
16
some of them,
weeks.
yeah.
Right. You've ACL, you get 3 visits for an ACL.
Really?
So if my bones are healed up maximally, let's just say 12 to 16 weeks, right?
You're
and we're just
done.
like, good luck.
Yeah.
How do we continue on? We see ongoing swelling in, joint replacement for a year. For 2 years. And it takes 18 months to really rework all those associated vascular networks. So how are we then saying, okay, this was the first phase, and now we're done with first phase. We need a different set of interventions and people to talk to after first phase. And I think what happens in physical therapy is wonderful care first phase, very acute. Let's protect you. Let's make sure we're getting you just moving. But now we need a different set of interventions to really maximize that. And when I talk to surgeons, just even about decongestion, oftentimes I'm like, hey, I don't think you're getting the outcomes you can actually get. I think you can get better outcomes if we think differently about this problem. And
almost one of the observations.
Sign me up.
Yeah, one of the things you're just making me realize, a common phenomenon, especially in long spine fusions, these kind of total lumbar reconstructions, let's say, especially in women, is around like the 2-3 month mark. A lot of them will develop like a hip bursitis, and it has something to do, I think, with their gait. The female gait's a little different, the pelvis a little different. And I think it's the mechanics are off because the back musculature is all recovering. Once that's recovered, but you've been spending 2 months walking funny, and now you have a trochanteric bursitis, bilaterally or unilaterally. But your insurance says you're done with physical therapy, so you're just home now, and the result's not there because your hips hurt every time you take a step, and now you're limping even worse from that. And that it's true. Unfortunately, there's a big gap, like right there. But there's a gap before any of this stuff comes to the system, and then there's the gap after. It's brutal, man.
My father's a physician. He's a family practice
Oh,
doc.
interesting. Yeah.
My grandfather was a flight surgeon.
Oh, wow.
And then became a radiologist after Vietnam. My daughter wants to be a physician.
Oh, wow.
And I think that there's real opportunity. I saw the life of my stepfather and grandfather, and I was like, nope.
Yeah. Yeah.
I don't want to.
That's
nope,
the problem.
not for
Yeah.
me.
Yep.
Now I'm like, ooh, maybe, maybe I made the wrong choice. I made the right choice, everyone.
Yeah.
But it's interesting to talk about this, for us to all begin to recognize that there's still so much opportunity
So much.
for better outcomes. And let's just drive it on outcomes.
Yeah.
I think I walked in, I can just only talk my own experience. Of course, I've rehabbed 1,000 surgeries, but going in 2 weeks later for my follow-up, and they're like, wait a minute, you haven't taken any OxyContin.
Right.
And you have full range of motion in your knee.
Yep.
And I'm like, yep. And they're like, what are you doing? I'm just like managing the swelling. That's all I'm doing.
Yep.
Like, I'm not squatting. I'm not being crazy. I'm just managing the swelling. Because you guys, and I think that blew their minds, because they're like, well, we don't know what to do here.
Yeah.
Because, you haven't been rate limited by poor adaptation response to the surgery.
Right.
And I think most of the time, I remember being a young first-year physio and seeing a meniscus allograft transplant.
Yeah.
And this guy came in and his knee was gigantic. And I was like, bro,
Right.
like, are you trying to reject this $10,000 meniscus? And I was like, what'd you have for breakfast? And he's like, a box of cereal. And I was like, what the hell is going on? And I had to teach this guy how to do all these things to eat. I'm like, stop eating a box of Fruit Loops for you. They're pouring gasoline on this thing. So what I want everyone to hear is that we're very much not in the business of pointing fingers.
Right.
We're very much in to say that we health care providers who aren't on the terminal end of being surgeons have failed people by not making the case, by not being clever enough getting into schools, of not really having honest, earnest conversations. Then we go see the physician, and the physician is, you're like, your car is on fire, and you take it to your doctor, your mechanic. The mechanic's like, whoa, like, stop this.
Yeah.
So that's, I think, sometimes how we're using our physicians. We're misusing our physicians.
That's probably a good phrase. It's so siloed. That was the funny thing to me. Like, I had to step out of that. Maybe that's what I was trying to say earlier. That attempt to reach out and get this deformity training, I had to kind of step out of neurosurgery. It was predominantly done by orthopedists, so I had to go over to a couple of the orthopedic hospitals, and you see how they think. And there's huge kind of gaps on both sides, right? Like, everybody's talking a different language within this one little field, right? We're all still in the spine surgery field, but we're all talking different languages. And if it's that siloed at those terminal branches, right, like way down where you're all in the same specialty field, but you're slightly different, and you guys still aren't talking the same language, how are you? And I was just never exposed to physical therapy, their principles. There's, where I work here in New York, there's a lot of chiropractors. We were never introduced to the chiropractors or where they're thinking from when they approach someone. And it's a siloing effect that's not helping any of the actual patients, right? It's probably a lot of ego. It's a lot of
and I think it's a normal expression of institutionalism.
That's true too.
Really, and I think we just have to be simultaneously conscious of it.
Yeah.
And as you are a clinician who starts to become competent, you can't just
stay in your lane, right? Like,
you have to now say, okay, I can do my job. Now I've got 5% extra. Now I'm going to go be curious. And that's tricky. You're buried under student loan.
Yep.
There's a lot of demands. You have productivity needs.
Yep.
But I need you to take that 5% and start to say, how do I reform? How do I tear down this wall and build another wall?
Yeah.
And that's the only way out of it. Otherwise, it's going to be really untenable.
You're super right about that too. There is that tricky problem where it's like you're so focused on your job, and the training gets you the training, but then you got to go get actual practice. So you got to stay in practice 2, 3, 4 years to get super comfortable. So now you're with with the right hand you can do physical therapy, physiotherapy. Now with the other 5% that's left over, go dig into kind of how these things are done. And if you're the surgeon, once you're totally comfortable and the stress levels dropped, take that extra 5% at the end of the day and go figure out, what the other professionals are telling your patients before and after, and learn about that, because otherwise you're completely ignorant to a whole whole field, the whole nomenclature, whole jargon. It's rough.
I like that. And I would just add one thing that we could do is also create a super network of people who are doing badass stuff.
Yeah, that's
So
true.
you meet one surgeon.
Yep.
You know, my wife was born with dysplasia.
Yeah.
Then had JRA as a kid. She's had bilateral, hip replacements. And she came in after her first hip replacement, and her surgeon was like, "What in the hell did you do? Like, we don't have outcomes like this. Why are you?" She'd done her long follow up, and he's like, "Well, I did a Spartan race, and I did a CrossFit competition, and I did this outrigger race, and I rode my bike 100 miles." And he was like,
Right.
"You're jacked. I'm not jacked." And he came to our gym and joined our gym.
Yeah, right.
And suddenly, I think that's what I want people to do. Is if you know a kick-ass surgeon who's thinking, that's the person you refer all your friends to.
Right.
And then you introduce all your physical therapists, and your nutrition. Then we create a super group where people are taking different times at leads, and then everyone's like, "I should have a super group." And I think we can still be thinking in that local. You don't necessarily have to go, "I've got 5%, let me reform, medicine."
Yeah,
That's not
right,
going to work.
right.
But you can start to create a super group of friends who are really having exceptional outcomes.
Yeah.
And those exceptional outcomes will speak for themselves. You save the hospital money.
Yep.
Patients are raving fans.
Yep.
They refer, like, you're booked. People are like, "What are you doing?"
Yeah.
And you're like, "Well, I had this health nutrition coach talk to my, this patient after surgery, and it just turned out they lost a bunch of weight and felt better because they were not inflamed."
Yeah, community.
That's
Community
cool.
of care. Kelly, thanks so much for doing this, man. I really appreciate it. Like I said, I've been a big fan for a while, so I'm a little bit fanboy right now, but I really appreciate your time. Love the book.
Thank you. We also, last thing I'll say is we wrote this book for a lot of reasons.
Yeah.
But we also wrote it because we knew that our physicians were so overwhelmed with time domain constraints that we said, "Hey, I know that we've got a lot going on, but I need you to read this book."
Yeah, right.
And start to get yourself ready for the surgery.
Start using this.
And that's right. And so we were like, could we create the ultimate manual?
Yes.
So that physical therapists can say, "Hey, as we're doing this, let's keep an eye on these
That's
things,"
what I was.
right?
That's exactly how I picture using it in the practice. And I was going to ask you, maybe I'll reach out to your publisher or something. They don't publish like little sections of the Supple Leopard book, do they? Like back, like they don't break that down. It's all one.
No,
one
but
thing. Yeah.
I give you permission to photocopy
Yeah.
anything you want and create little things to go use it in the world. The thing's 10 years old. Go beat up. We're working on another edition.
Oh, cool.
But just keep in mind that I totally empower you to chop it up and serve your people. That's what it's for.
Perfect. Appreciate it, Kelly. Thanks a lot, man.
Thank you so much.
Bye-bye. Did I leave?